Ladies and gentlemen, in the first part of my presentation, I would like to summarize a study recently accepted by Osli Retina, and it talks about 88 eyes of 88 patients who were examined either before or after surgery. Here you can see an example of a macular hole in Schwetzer's OCT angiography. For those of you who are not familiar with this examination technique, the orange circle at this side represents the superficial retinal layers. The green rectangle would represent the deep retinal vessel layer. The light blue rectangle represents the avascular zone, and the dark blue rectangle represents the choriocapillaries. Now look at the arrows. The arrows point at a small deformation at the margin of the avascular zone in deep retinal layer plexus, and it corresponds to those cystoid spaces visible on OCT. In the choriocapillaries, you see a hyperreflective circle in the middle, which is corresponding to the lack of perfusion in the middle of the macular hole. Now it should go in another direction. Okay. If you look on Schwetzer's OCT angiography images, note that everything that is white means flow and everything black means no flow. But of course, if you look at the middle of those large macular holes, you can see a large white circle, which does not mean a lot of flow inside. It is an artifact. It might be caused by a light transmission, increased light transmission, or if you look at those white arrows, at a segmentation arrow. So this segmentation error occurs in all macular holes in spectral domain OCT and also in Schwetzer's OCT angiography. It can be removed by external software, as you can see here, like Adobe Photoshop. Another artifact visible in full-thickness macular holes is the jellyfish-like artifact. Please have in mind that the vessels you see in OCT angiography are only those which are located in between the segmentation lines. As you can see in this animation, everything below or above the segmentation lines becomes not visible. And this segmentation error might be now removed also by internal software inbuilt in the device. Macular holes are a model disease, but all the segmentation errors or the artifacts visible there might be of special importance, for example, in diabetic or other macular edemas. So please be very careful when interpreting the images by OCT angiography. We concluded that the fovea avascular zone in deep retinal layers negatively corresponds to final retinal thickness. So patients with a large fovea avascular zone in deep retinal layers have a very small retinal thickness. Looking at the fellow eyes, they have also some defects in the choriocapillaries that might be an explanation of the fact that macular holes form much more frequently in fellow eyes of full-thickness macular hole. In the second part of this study, I would like to talk to you about 30 patients examined prospectively both before and after surgery with OCT angiography. In all patients, we performed the temporal ILM flap technique. You are, I hope, familiar with that. We peeled in this technique the ILM only from the temporal side of the macula. We all know that the ILM is the base membrane of Müller cells and that they are interconnected through the retina. We are also aware of the fact that ILM peeling causes retinal nerve fiber layer defects in the temporal flap technique only on the temporal side. But looking at the same images, both before and after surgery, we observed that in the exact area where the ILM was peeled on the temporal side, there was a decrease in the density of the vessels in the deep retinal layer plexus. So in conclusion, I observed two artifacts, the hyperreflective circle and the jellyfish-like artifact in Schwetzer's OCT angiography. The fovea vascular zone in deep retinal layers corresponded to final retinal thickness 1 month after surgery. The choriocapillaries are altered not only in macular holes but also in the fellow eyes. And deep retinal vasculature might be altered in the area where ILM was peeled. Thank you for your attention.
Thank you, Zofia. Let me ask a question. I know you are biased toward the inverted flap technique, but does it make a difference between ILM peeling and ILM peel and invert? I mean, peel and remove and peel and invert. Does it make a difference in your findings on the OCT angiography?
ILM peeling has some influence on the density of the deep retinal layer plexus. So we observed that in the areas where the ILM was intact, the deep retinal vessel plexus normalized in some way. But in the areas where the ILM was peeled, and it was very easy to say because we peeled it only from the temporal side, there was a decrease in the deep retinal layer plexus at least 1 month after surgery.
Okay, thank you.
Thank you very much, Nicola Ghazi from Cleveland Clinic, Abu Dhabi. Again, I noticed similar artifacts in spectral domain, OCT, angiography with central serous retinopathy. I always see this ring of hyperfluorescence at the base of the elevated retina where the shaggy photoreceptors are. And it's difficult to localize it cross-sectionally to exactly where it belongs. Have you observed this, and do you think we can remove this also by the new software you have?
I think OCT angiography is an extremely new technique, and the most important thing about it is knowing the artifacts, just to better understand all the diseases. I'm sure all the artifacts can be removed somehow, but it depends on the device. We work on swept source OCT, but I'm also sure that spectral domain artifacts can be removed by external software. Internal, you have to ask the individual company.